Hi everyone, and welcome to my presentation about patient eligibility for the palliative treatment of painful bone metastases using MR-HIFU. My name is Renée Hovenier. I have a background in technical medicine, and I'm currently working in the UMC Utrecht in the Netherlands on the further study. This is a big multi-centered randomized controlled trial concerning patients having painful bone metastases. I will tell you more about the further trial and the exploratory study we did within this trial. So as we know, malignant tumors have become a major public health problem worldwide. The bone is one of the most common sites of secondary metastases, together with the lungs and liver. Bone metastases are associated with morbidities, including pathological fractures and severe pain. Especially this bone pain truly limits daily functioning and reduces quality of life. So at this moment, current standard local treatment of painful bone metastases is external beam radiotherapy, EBRT. However, it may take up to 4 weeks to induce maximal pain relief, and EBRT does not induce any pain palliation in 30 to 40% of patients, while rapid and effective pain relief is one of the main goals of this treatment. A promising alternative is MR-HIFU. Treatment with HIFU is aimed at local periostal denervation by heating the cortical bone, which prevents the transduction of pain signal and thus relieves bone pain. MR-HIFU has been shown to induce a fast pain relief and may therefore improve pain palliation in non-spinal metastases. Since the role of MR-HIFU as a first-line treatment option is still unclear, studies are being conducted to compare MR-HIFU to the standard treatments. With the help of funding from the European Commission, an international consortium has been set up to evaluate the effectiveness of MR-HIFU as a primary palliative treatment option. The further study investigates whether treatment with MR-HIFU in combination or not with radiotherapy produces a faster pain relief than radiotherapy alone. So 6 hospitals in 4 European countries, all of which are partners of the further consortium, are participating in this prospective multi-center RCT trial. So we include all patients with painful non-spinal bone metastases who are referred for radiotherapy. After informed consent, the patient is randomized into one of the 3 treatment groups, one radiotherapy, MR-HIFU, or a combination of both. In total, 216 patients with painful bone metastases will be randomized in a 1:1:1 ratio. However, compared to EBRT, MR-HIFU is a more complicated procedure which impacts the in- and exclusion criteria of the study. For example, the need for sedation makes the overall condition of the patient an important factor for in- or exclusion. In addition, there are some specific technical constraints for the treatment, such as the location of the metastasis or the size of the metastasis. These factors determine the success of the MR-HIFU treatment, whereas EBRT can be performed much more easily. So this makes MR-HIFU a really different treatment modality than EBRT, and these modalities may therefore also serve a different patient population. So it's therefore useful to assess the potential role of MR-HIFU within the patient population of the further trial, so patients having non-spinal painful bone metastases. In addition, insights in the causes of ineligibility will help navigate further research aiming at increasing the availability and accessibility of MR-HIFU. So in this prospective study, the 2 Dutch hospitals participating in the further trial participated. In the UMC Utrecht, all patients referred for radiotherapy between January 2022 and May 2020 were included in this analysis. In Isala Hospital in Zwolle, patients referred for radiotherapy between September 2020 and October 2021 were included after protocols pre-selection by a medical planner who excluded, for example, patients having spinal metastases or hospitalized patients. All included patients were assessed for eligibility for MR-HIFU by an interdisciplinary team, and for each ineligible patient, the main reasons for ineligibility was reported. So overall, 246 non-spinal bone metastasis patients were screened for eligibility. This resulted in 256 ineligibility causes. So as you can see, there are more reasons noted than the total amount of patients. How come? In some cases, two things immediately stood out that made a patient ineligible. At that point, you can no longer decide which of the two was the primary or the most prominent reason, so then both of the reasons were selected. In total, MR-HIFU could serve as an alternative treatment to EBRT in only 10% of the patients. The other patients were thus ineligible for one or more reasons, which we looked into in more detail. So in this bar graph, all ineligibility reasons were plotted with on the y-axis the total amount of cases and on the x-axis the most prominent reasons. So we found 6 main categories for ineligibility. The largest group is that the target lesion is not completely treatable, for example, a too big lesion, followed by the risk of a pathological fracture and oligometastatic disease with a curative treatment plan. To keep in mind, these are exclusion or ineligibility criteria specifically for the further trial. If we look from a HIFU perspective, the 3 most right categories are not suitable for HIFU. For example, no pain means that we cannot induce any pain palliation. But the 3 groups on the left are excluded based on the need for radiotherapy. But this does not specifically mean that MR-HIFU is no option. So patients in these groups might benefit from an additional MR-HIFU treatment. However, we must also note that only the most prominent appearing reason was collected. So as an example, let's say this is a sample of the population and they were all assigned to one of the ineligibility reasons. So the distribution may look like this. However, we're not sure if any of the other reasons apply also to a patient, since only the first and most prominent reason was noted. So it might have looked like this. Our approach thus may have caused underreporting of all ineligibility reasons. So we're currently doing a more systematic and in-depth study in a focused cohort to assess the prevalence of all ineligibility causes, so we can map how big the role of HIFU might be in this patient population. And furthermore, due to the randomization structure of the further RCT, there are 2 additional limitations. So one, we only looked into patients referred for a radiotherapy treatment, which is a restricted population. And 2, we looked for patients in which MR-HIFU could replace EBRT as a standalone treatment, since this is necessary in the further trial due to the randomization part. However, in the real world, MR-HIFU could also be performed as an additional treatment option for pain palliation and does not necessarily need to be interchangeable with EBRT. So if we look back to our patient sample, all these patients were excluded based on one of the reasons above. However, as I mentioned earlier, patients within one of the 3 left groups might be eligible for additional HIFU, but they were excluded because of RCT reasons. In addition, there were some patients who were not assessed in the study since they were not referred for radiotherapy. So those might benefit from MR-HIFU as well. So all in all, if we look back to the results, this screening study in patients referred for radiotherapy indicates that MR-HIFU as a first-line treatment might only be feasible in 10% of patients. This might also thus have an impact on the inclusion of the further RCT. However, the patient population of this exploratory study was not exclusive, and MR-HIFU may have a role to play in a broader population. Especially looking into the combination of MR-HIFU with EBRT could increase the number of eligible patients. So this could be investigated in a more detailed study to examine its potential in local pain palliation in non-spinal bone metastases. So I thank you all for listening, and I'm glad to answer any questions you might have.